everyone. Welcome back from lunch. This is the session that will be wrapping up sort of Medicine X. It's been a nice long weekend, huh? So we have an awesome session today about really innovating for specific needs or really trying to solve a narrow problem with a concrete solution. And coming from where I am and what we've seen at Medicine X this year, I actually think that that's one of the best ways to go about coming up with true solutions. I'm not going to take too long here. I'm introducing James Suliburk, who is an assistant professor of surgery at Baylor College of Medicine, and will be talking to us about the use of evidence to really develop an app, so really solving a content problem. And I'm challenging all our speakers today to try to get their talks done in the 13 to 15 minute mark so we can challenge them with questions. So I'm challenging all of you guys to bring up those questions once they're done. All right, James, go ahead.
Go. So my name is James Suliburk. I'm a surgeon in Houston, Texas. I'm in academic surgery at Baylor. And so I'm talking with you all today as a partner in trying to solve some of these problems, but I'm bringing the perspective of the front lines of care. Part of my job, I work at Bentab Hospital, which is a public hospital, level 1, county-funded trauma center. And then part of my practice is at a tertiary referral center where I see patients who have good insurance. So 130, 6.8 billion, and first do no harm. And I'll start my talk by telling you how I became part of 130 and how I contributed to 6.8 billion, and I violated the rule of first do no harm. So 130 is about the average number of people that come into contact with a patient who's undergoing surgery, whether it's from the pre-op phase of care, inside the hospital, or even through the post-op discharge by the time they walk out the door. 6.8 billion is the annual cost of surgical complications in the United States. So that exceeds the gross domestic product of more than 100 countries worldwide. And first do no harm, I'll take you back 15 years to about this time of the year when I was a second-month intern working on pediatric neurosurgery. So I'd been up all night, and one of the procedures that we did were to take children who had severe epilepsy, perform a craniotomy, that's removing the skull, and implant electrodes on top of the brain, and then put the skull back on, take them off all of their epilepsy seizure medications, take them to the epilepsy monitoring unit, and let them seize, map out the focus of the seizure, then come back and resect that part of the brain and cure them of their intractable epilepsy. So on a Monday morning, I'd been working all night, and I came in and I got a call from the ICU that our patient who had just had the initial portion of the procedure done was with the transport team and was coming back to the ICU and had some bleeding going on from the dressing. They were very concerned about it, said it was bright red and it was squirting. So I stopped what I was doing, ran over to the other part of the hospital where the pediatric intensive care unit was, and examined the young boy, and sure enough, he was hemorrhaging from the dressing that was wrapped around his head. So I did what I thought I should do. I started trying to help the person, but I was really an MS4 plus 2 months. So I grabbed my trauma shears, that's a picture, so if there's any clinicians in the room, you know that these are what the med students and the interns and everybody carries with them. They cut through pretty much anything. So I started cutting off the dressing on the child's head. And not only did I cut off the dressing, I cut all the wires that were on the child's brain to monitor him so that we could cure him of his epilepsy. And in that moment, 15 years ago, I will never ever forget how empty, worthless, vulnerable, and small I felt right in front of that child's dad, his mother, him, the whole staff of the ICU, and ultimately my program. So I had the review and they kept me, and here I am 15 years later. I'm a fellowship trained surgeon at a top 20 medical school in the United States, and we've moved on from there. But every time I work in this type of environment, I go back to that moment 15 years ago where I was actually part of the problem, and that's one thing that drives me to find innovative solutions. So when we talk about digital health and app development, we do see that there's probably some promise, but it's yet to be realized. And part of the problem with current modern day approaches are that this is a really complex healthcare environment, and the usual mock-ups that go from idea to app forget the first principle in design, which we've learned about through this conference, at least I've learned about, and that is get the input of your stakeholders. And so in these usual wireframe stepwise algorithms, there needs to be an actual clinical step to get clinical input and patient input. And one of the problems that clinical input is so hard is because in medicine, there's actually very little evidence for the things we do. And this is one of my favorite articles from the Mayo Clinic, which was published just in the last year, where they looked at the #1 impact journal that we in the medical world follow, and that's New England Journal of Medicine. They looked at a decade of articles in the New England Journal of Medicine that examined practices that we do. What they found were that #1, stuff that's published has a huge bias to it. So 3/4 of the studies only show positive findings. Okay, so right there, that tells you there's a big bias going on. And this is the #1 journal in the world. #2, in articles that examined standard of care practice using rigorous trials, 40% of the standard of care practice actually was reversed when it was scientifically examined. And so when we start talking about trying to tackle some of these problems, it's important that we understand where we're starting from. And the truth is, in a lot of things, we really don't know. We do stuff just because. And so Albert Einstein said, we can't solve our own problems with the same thinking we used when we created them. And so our research group at Baylor and our small startup Synced Care has developed this methodology in order to approach developing content for apps. We are starting from the clinician side first. We're not entrepreneurs, we're not programmers, we're not coders, we're not designers, but we're starting from the clinician side first. And we acknowledge that you have to take a very careful look at the literature, incorporate evidence where you can, and then where you can't, which is the majority of time, be able to truly identify what the expert consensus is and whether or not it's right or wrong. Once you get that consensus, you can then start to get your mind around what clinically actionable content is, then go into a design cycle focused with patient literacy, focus group feedback, human factors engineering, and eventually at the very bottom end with patient-centered content. And I'll go through a couple of case studies that we have in clinical trial right now in our hospitals, and one will go through colorectal surgery, and another will go through thyroid surgery. So colorectal surgery is very attractive to study from a clinician's point of view because it carries with it a 30% complication rate. So when you design proper trials, you need lower numbers of patients to be able to power it adequately and show a significant difference. Thyroid surgery is interesting to me because I'm a fellowship-trained endocrine surgeon, and there's a movement right now to do this procedure outpatient instead of inpatient, so there's an interruption in traditional transitions of care. A couple years ago, folks with my research group studied this. We came up with patient-centered early warning factors to prevent readmission after colorectal surgery, and we used a health services research methodology called the Delphi method. It's developed by RAND Corporation many years ago. And we're leveraging a variation of this in order to develop further content. The trick is to go from a scientific manuscript like this to working your way through with the human factors design engineering content that's actually understandable by our patients. And what we end up with is something looking similar to this, where you have color-coded signs, easily able to understand font, taken down to a 5th grade readability level, and that are based on sound clinical endpoints. And when we examine the types of patient population that we deal with, we work in both a safety net environment as well as some other hospitals in the Houston Metroplex. And when we actually go to our patients and survey their educational level, 35% of the patients I see at my safety net hospital have only an 8th grade education. Another 30% have at most a GED equivalent. So this is a very challenging thing, but we are not going to let that be a barrier to us in terms of communicating with them. So in thyroid surgery, I put together a work group with colleagues from across the country and actually across the world to look at discharge content for that. And we used the same methodology. And when we synthesized everybody's discharge content, these are the centers of excellence. So this is name brand institutions, Ivy League schools, tertiary and quaternary level care medical centers all across the United States, Canada, and Australia. And if we look at the average reading level, it's about 9th grade. So only 2 centers had health literacy appropriate information. We took all that, we synthesized the data, we had an online virtual meeting, we ran our Delphi methodology, and in 4 days, which that sounds like a long time if you're in the tech IT development world, but to get 17 surgeons to get consensus on more than 160 data points in only 4 days, that was a momentous leap forward for us. So we went from something like this to something like this to finally something very simplified. And now we have content that we can use for the verbiage and the language from this, and then take that to a digital level, display it on patients' devices in a font and color-coded that it's easy for them to read, so that now we can safely discharge folks and be confident that through that education process, we're going to be giving them content that they can understand and read. Why is this important? So you can get the scale of it real quick. In my hospital, I do a little bit over 100 thyroidectomies a year. The cost of an overnight stay in our safety net system is $2,500. So I've saved the hospital almost $200,000 in 1 fiscal year. Well, how many thyroidectomies are done in the United States nationwide? It's about 100,000 thyroidectomies. So the potential cost savings there is all of a sudden $200 million. And so we believe that there are surgical black holes that exist between the pre-op area, where the patient comes and sees me for surgery, the inpatient environment, and when the patient comes and sees me outpatient. And we want to take advantage of these black hole time periods and use cloud-based technology to deliver content to the patient so we can get them the right information at the right time and optimize their surgical outcome. We truly believe that through proper patient engagement, we can empower them with the knowledge they need to facilitate communication and then improve our quality outcomes. And currently, I'll fully admit that we practice in the world of the rotary phone. Clinical medicine today, wherever you go, is practiced like you're still using the rotary phone. And until we can all come together and take advantage of digital technology and modern day electronic communication, we're not going to get any farther ahead. And what our group focuses on is developing the content to be delivered through those technologies. We're only a small piece of the puzzle. This is my first Medicine X, and I really enjoyed the meeting. Part of the reason to come out here was to collaborate, get ideas from everybody else who's here, who's working on this same exact problem, and give our perspective from the clinician side of things, and say, hey, we're here to partner with you all. We'd love to talk more about it. You can find myself or any of our research group members online, and thank you very much.
All right, you met the challenge. We have 7 to 8 minutes for questions. Who wants to start?
Could you just talk to the Really nice job. Could you speak to the challenge of doing this kind of patient-centered research as a surgeon in a large academic center? I mean, this is certainly non-traditional when you look at what surgeons do. What are the challenges you faced there?
So there are very significant challenges to doing this type of work. Number one, this type of work is very difficult in the academic medical world to get funding, to get grants that support this type of work. But we firmly believe that these patient-centered types of projects are actually the way forward. It's very, very competitive to get grants right now in the modern funding environment. These types of grants that support this are funded at less than 7%. So that means you've got to send in your grant to at least 10 to 15 different agencies. Hopefully it's a perfect grant even if it's a perfect grant, you still may not get it funded. The traditional academic medical centers really struggle with this because it's not traditional academic research, especially for surgeons. But we've got a group with this. There's a big movement behind this, and we're trying to move it forward.
With your outcomes data and kind of your traditional Delphi-style consensus, have you gone back to the literature and back to your professional organization? I know the ASA loves that guideline building.
So the answer is yes. So those thyroid discharge instructions, I've got to be careful with it because we're presenting the thyroid discharge instruction stuff at the American College of Surgery that's upcoming at the end of October here. And we are partnering with the American Thyroid Association, the American Association of Endocrine Surgeons to distribute this stuff free to colleagues so that they can start using these type of materials to help empower them. As busy modern day clinicians, people actually don't have time to do this. The only two centers that had decent literacy level stuff, the reason they had it is because they had dedicated health education departments within their nursing schools that all the materials had to be vetted through those departments before they could be given to patients.
I thought that was a wonderful presentation. Thank you. And we seem to have a lot of the same challenges where I'm working. Now, one question I have for you is, I think it's on the right track to finally be going back to, okay, let's create quality content and actually make sure we're after the right objectives and the right outcomes when we create a tool. The hard part for us is actually getting the tool, once it's conceptualized, built, or getting it conceptualized in a usable and useful format that follows kind of those user experience principles, which is not a very innate thing for health researchers. We don't even speak the same language.
Yeah.
So how are you handling that?
Great question. So we struggled with this exact same thing until we were actually fortunate enough to be cold called by a startup tech collaborator firm who said, hey, we really like this content that you've developed. You want to put it on our platform and let's see how it goes. So we're actually in the midst of a 30-patient trial right now with measured, established health services research clinical endpoints to determine what's the utilization, what's the cost, what's the reduction in readmission, did we convert potential inpatient complications to being able to be managed outpatient, and what was the patient satisfaction. So we're generating that pilot data off a 30-patient pilot trial right now. And if I can give any advice to colleagues that are out there working in academic research that trying to move this stuff forward, what we had to do was form our own LLC. So we're all full-time Baylor faculty, but we had to form our own LLC and spin that off out of Baylor, talk with our institutional intellectual property office and Office of Technology, and they said, you guys will take our X percentage cut, and then that freed us up to be able to be very agile and to negotiate with the tech startups to put their platforms into use. We've got this massive clinical operation, this massive load of patients, and this enormous opportunity, but in order for us to complete the puzzle and get that tech collaboration, that's how we solved it.
With IRB?
Yeah, absolutely. So this is fully licensed, full IRB, disclosures, consent, sign up. This is a running clinical trial.
And hospital administration was cool with that?
Yes.
As an LLC, were there restrictions Were there restrictions on the type of access you'd have to your patients, or restrictions on what you would do as part of an LLC as opposed to if you were still at Baylor, if you hadn't gone that route?
So the answer is that there are restrictions for me being involved in knowing the outcomes of the clinical trial, because I can't bias the own trial, because that would be a significant conflict of interest. So I don't actually know the results of what's going on right now. I know that we're enrolling patients, but I couldn't give you any preliminary data. I'm blinded to it right now. With regards to being part of the LLC, again, that's more a technology transfer type situation where we find it much more flexible to be able to work with folks as an LLC, as opposed to having all those documents signed through our Office of Compliance, the lawyers, everything else, and ends up with a 4-month cycle of review of paperwork, and we need to be more agile and nimble to move on past that.
All right, James. Thank you. That was awesome.